Hi, this is Dr. A, and this is your last video for Intro to U.S. Healthcare. We are looking at Chapter 14, and this one's going to be an analysis of the U.S. healthcare system, and we're going to look at it and compare it to some of the other international healthcare systems, and we are in the 5th edition of the Basics of the U.S. Healthcare System. All right, so although the United States can provide state-of-the-art healthcare, we are reminded of the IOM report that estimates 44 to 90,000 annual deaths as a result of medical errors. As with any large system, there are system errors. The United States is not the only country with a healthcare system that has problems. Countries with national healthcare programs provide universal access to healthcare to all citizens. They usually have a single-payer system, which means the government pays for healthcare services, or it mandates payments into, some funds and stuff. There are 3 models for structuring a universal or national healthcare system. There's national health insurance, as in Canada. And it is funded by the government through general taxes, although the delivery of care is by private providers. But the collection of the money and the paying for it is done through taxation in a national insurance. In a national health system, such as in Great Britain, taxes support the system, but the government also manages the infrastructure for healthcare delivery. Meaning the hospitals and other medical entities are owned by the British government. They also collect taxes and pay for the health services and the coverage, all of that. It's all one system. But as a healthcare worker, you would be employed by the government of Great Britain. In a socialized health insurance system, as in Germany or France and many of the other countries in Europe, the government mandates financial contribution by both the employer and the employee, with private providers delivering health care. And so here the role of the government is to mandate that this happens. So this is close to what the ACA was trying to do with mandating that healthcare must be purchased. And so this is the closest to the system that we were trying to implement in the U.S. The first one here, the one with Canada, the national health insurance one, is maybe more similar to the idea of the Medicare for all for the U.S. Japan, Switzerland, and France were selected as a comparison because of their quality health service indicators. Okay, so let's start with Japan. So Japan has one of the highest life expectancy rates. Their healthcare system is regulated by the Japanese government with the statutory goal of providing quality care. Citizens have to be covered by any of the following components of what they call their social security system. Now, the meaning of social security system in Japan is different than the meaning of social security system in the U.S. So people are covered through social insurance, social welfare. Again, welfare would have the same meaning, meaning it's usually applied to people that don't have a lot of funds, public assistance, and public health. And so those are, the main ones, with the social insurance probably being probably closest to the healthcare system, the health insurance system in the U.S. They had a 2015 Healthcare Reform Act where local governments are now responsible for the oversight of community healthcare plans and collecting the premiums. Those older than 40 years of age are automatically enrolled in long-term care insurance, which I think is really interesting and a really good option. In the U.S., there is no such thing. With the graying of the population, approximately 90% of Japan's healthcare costs are the result of the elderly utilizing the healthcare system. It is anticipated that Japan will triple spending on healthcare in the next 20 years. They have more than 4,000 community comprehensive support centers to coordinate services for chronic diseases. And access to the healthcare system is patient-friendly, which creates an overuse of services, increasing the government's healthcare costs. So they are not shy about going to the doctor, and it's not expensive to go, so they use their services often. Okay, so next let's look at France. France's healthcare system has many characteristics of a socialized health insurance program, similar to Germany and Japan. The system consists of statutory health insurance called SHI that is funded by payroll taxes. So that's about 50% of the funding there. There's also a national income tax that contributes about 35% of the funding. And then alcohol and tobacco taxes, the drug industry, and voluntary health insurance companies are the other 13%, and some state subsidies are 2%. There is universal coverage for approximately 99% of French citizens. Their system has faced tremendous deficits over the past 20 years, but the deficit has decreased dramatically as a result of some countrywide initiatives to control healthcare costs. So these initiatives have included the reduction in the number of hospitals, the removal of 600 drugs from the public reimbursement schedule fee, so they're no longer buying them or reimbursing for them. And of course, they offset that by increasing the generic drug prescribing with the increased use of over-the-counter drugs and cost containments via central purchasing for drugs, where the government negotiates prices for the entire country for certain drugs. Compared to the United States, life expectancy is higher, and infant mortality, heart disease, and obesity rates are lower. The French government makes it very difficult for insurance companies to deny coverage because of pre-existing conditions. Citizens who are very ill receive increased care and coverage, unlike the U.S. system, in which individuals may go financially bankrupt because of their cost sharing during a chronic disease. So this is a good model. If you need more help, you get more help. The government is now requiring physicians to reduce the number of drugs they prescribe and to substitute generics, which will save approximately millions annually. All physicians in France participate in the nation's public health insurance, very similar to Medicaid. Medical schools, although extremely competitive to enter, are tuition free, right? Therefore, French physicians enter their careers with minimal debt, and I think this is a pretty cool system. They pay much lower malpractice insurance premiums because their lawsuits against physicians are much less common in France than in the United States. It is interesting to note that the French government allows physicians to charge more than the government's reimbursement schedule, although physicians employed by hospitals are not allowed to set their own fees. And so this is where, physicians can make a little bit more, although they don't make the same level of salaries as doctors do in the U.S. They also come out without any medical school debt, whereas doctors in the U.S. can come out with hundreds of thousands of dollars of medical school debt. Next, let's look at Germany. So Germany has one of the oldest universal health insurance programs, dating back to 1883. Health insurance for hospitals and outpatient care is mandatory for all residents. Approximately 90% of the population is enrolled in the statutory health insurance program, which provides hospital care, outpatient care, mental health care, and prescription drug coverage. They also have sickness funds, which are non-governmental insurance companies that are financed by wage contributions, which are paid by the employer and employee. So that is only about apparently maybe 15% of the population, a little bit less than that, or 50% of what's paid into healthcare. The residents who make more than $68,000 a year can purchase private health insurance to supplement the already public, their SHI. Right? The Ministry of Health, similar to the U.S., the U.S.'s CDC, is responsible for infectious disease control and provides routine reports on public health issues. Since 2015, electronic health records are used nationally, similar to the United States. The government has also started to focus on linking hospital payments to quality care. A positive of the German healthcare system is the mandated long-term care insurance model. Like many countries, the aging population uses the system more, so having a long-term care insurance plan in place is invaluable. Again, the problem here in the U.S. is that most people do not plan appropriately for long-term care. Switzerland's healthcare system is considered one of the best in the world. All residents are required to purchase health insurance, so in a sense, it is a country with universal healthcare coverage. Approximately 99.5% of Swiss have health insurance. The insurers cannot reject an applicant based on health status. Healthier consumers pay higher premiums to subsidize the cost for the less healthy. The insured pay twice the amount of out-of-pocket expenses than in the United States, right? Citizens pay more for health insurance than those in other European countries. So if you look on how much is spent per GDP and all of that, Switzerland is probably the next in line. Like when we look, US spends the most, but then the next would be Switzerland. They're still spending significantly less than we are, but they're spending the most of the European countries. Government controls prescription drug prices, of which consumers pay about 10%, meaning the Swiss government negotiates with drug companies to set the prices for the country. National e-health service called eHealth Swiss is coordinated by the government. All providers must collect and store patient information electronically, and any health-related websites where the information is collected must be quality certified. This allows them to look at population-wide metrics across all the systems, which is a really cool system. Increasing quality of care is a government priority, which includes a network for quality programs such as drug safety and reducing hospital infections. So let's look at a couple of examples within the United States. So we have the Massachusetts Commonwealth Health Insurance Connector. So in April 2006, the state of Massachusetts passed legislation to implement a type of universal health care coverage. The legislation mandated that all adult residents obtain health insurance coverage by July 1st, 2007. The cost would be based on the individual's income. For those residents who did not register, a financial penalty then would be assessed. As part of the reform, Massachusetts established a clearinghouse called the Commonwealth Health Insurance Connector, which facilitated the buying, selling, and administration of affordable, quality, private insurance coverage for small businesses and individuals. In 2022, the uninsured rate in Massachusetts across all demographics is 3%, which is the lowest in the country. So again, they did, before the ACA was passed, they did a model very similar to it, and it looks like basically the ACA with the health insurance marketplace was trying to bring what they did nationwide. So their uninsured rate in Massachusetts is 4% in the American Indian Alaska Natives compared to 19.6% uninsured rate in the U.S. It is 2.8% in the Asian population versus 6% in the U.S. It is 4.26% in African Americans versus 10.5% in the U.S. It is 5.33% in the Latino population versus 17.94% in the U.S. And it is 2.29% in the Caucasian population versus 8% in the U.S. and 4.53% in the multiracial population. So they have very low uninsured rates compared to the rest of the country. The major problem resulting from the program is there is a shortage of primary care physicians. Many formerly uninsured people require the services of a primary care physician. So of course it had an influx of patients in the system and did not have enough providers. Hospitals, however, are seeing fewer uninsured patients, and visits to the emergency room for primary health care are down by approximately 33%, which is really good which means that when you go to the emergency room, you are able to get emergency care because it's not being bogged down by people just seeking just regular health care in the ER because they don't have health coverage. A similar model called Healthy San Francisco was done around the same time. So in April 2007, Healthy San Francisco was established, making comprehensive healthcare available to the 73,000 uninsured San Francisco residents that were aged between 18 and 65 years of age. Any resident is eligible to apply to the program regardless of income status, pre-existing condition, or immigration status. Those eligible must choose a primary care provider home among several clinics, and they are provided with an identification card and a handbook explaining the services. Small fees are charged based on income. So let's look at some lessons to be learned. Japan, France, Germany, and Switzerland have different types of universal health insurance programs, but their systems all have flaws. Although Japan ranks at or near the top in the OECD country rankings for infant mortality rates and life expectancy, its healthcare system has problems. In Japan, as in the United States, the elderly use the healthcare system more than any other demographic, and as a result, Japan's healthcare spending is expected to triple over the next several years. In the United States, Medicare spending continues to be an issue. However, the ACA has developed financing models for Medicare and Medicaid providers that may rectify this major problem. The CMS Innovation Center has created different finance models for quality and cost-effective care. In France, unlike the United States, employers are mandated to pay a percentage of the employee's salary to a national health insurance program, not a private health insurance plan. In France, taxes on tobacco, alcohol, and pharmaceutical company revenues are used for healthcare. I think that's actually a really good model. Similar to the United States, private health insurance companies participate in the healthcare industry, with 90% of citizens purchasing supplemental insurance. However, unlike in the United States, the sicker a French resident becomes, the more coverage they receive from the government, which, if you think about it, really makes sense. There is a mandate in the ACA that prohibits health insurance companies from denying coverage based on catastrophic illness. That mandate is a positive step in improving healthcare for those who are seriously ill. There are 30 chronic conditions for which the French government will pay coverage, such as cancer and diabetes. In the United States, some citizens become bankrupt if they have chronic conditions because they cannot pay for the out-of-pocket expenses, and some have to make choices between, buying drugs and food or rent. It's just really kind of a big problem in the U.S. Like the United States, France has developed a managed care type program that encourages citizens to select a provider who will become the gatekeeper for their care or pay a higher amount out of pocket. Managed care contained costs in the United States during the 1990s and has become commonplace in the U.S. healthcare system. The accountable care models are another step towards cost-effective and quality healthcare, and the accountable care models are used for Medicare patients in the U.S. Swiss insurers cannot reject any applicants based on their health status. They also cannot make any profit on the basic insurance package, but they can make a profit on the supplemental insurance packages that most citizens buy. The Swiss government supports the indigent or poor, like the United States does with its Medicaid program. The ACA requires insurance companies to spend at least 80% of premiums on providing quality care. So that's the same thing where a lot of it cannot go for profits. The ACA has also imposed a flat annual fee on pharmaceutical companies, makers of medical devices, and health insurance providers, and this is based on their market share. There is also a 10% tax on indoor tanning bed facilities. So this is another way to kind of mimic some of what is being done. So trying to compare all the things here. So in conclusion, the U.S. system continues to evolve. Technology will continue to have a huge impact on healthcare. Consumers have more information to make healthcare decisions now because of information technology, which increases health literacy and is a really good thing. Telehealth delivers effective healthcare services and provides education to the healthcare consumers. The elderly strain healthcare systems because they require more services like long-term care. Models such as the Greenhouse Project and the Village Movement demonstrate different care models for the elderly that emphasize more independence, and those are really good models to follow. All countries have problems with their healthcare systems. The United States has excellent healthcare, although there are health disparities due to unequal access to healthcare. The initiative to require individuals to purchase health insurance has been resisted and difficult to implement, but more individuals now have health insurance coverage thanks to the ACA. The biggest challenge the United States faces is dealing with long-term care issues. People are living longer and will require more care, and long-term care is very expensive, and people aren't planning adequately for their long-term care expenses. Surveys indicate U.S. citizens are concerned about rising costs of healthcare services, and that also needs to be addressed. And so this wraps up our entirety of our Intro to U.S. Healthcare System course. I hope this was helpful for you, and I will see you again on my YouTube channel.